Professor Daak. Yes, exactly. That's what we're going to do. We will be waiting for the others to join. And meanwhile, we're going to kick off this first webinar organized by African Global Health and by African Health Business. Thank you to everyone who joined us, who will be joining us. So this meeting is under the theme Youth Crime and Addiction, the harm reduction measures to avoid youth crime related to addiction. So as you know, a lot of minors in state juvenile justice in every part of the world were under the influence of drug or alcohol when committing their crimes. They were tested positive for drugs. So today we are here going to discuss this very important subject with the presence of our esteemed experts. I would like to start by thanking them for agreeing to be with us today and to speak on this important matter. So Professor Salah Daak actually had very hard time to connect today, and we thank him because we know he's very busy and he doesn't have internet much due to his work. So thank you very much, Professor Salah, for being with us today. I would like also to thank you, Professor. So I will be moderating. I am Dr. Sarah Twersi, and I would like to thank Professor Morgan Chetty, who always agrees and he's always ready to help whenever he can. I would like to thank Dr. Enrique Terran, who also agreed to help, even though he is a professor and he was actually working today. I think I don't know what he did to manage to be with us today. So muchas gracias. And Dr. Daniella Munene and Dr. Mili Fares will be joining us very soon. Dr. Daniella Munene is from Africa Health Business, and Dr. Mili Fares is a pulmonologist from Tunisia. So I will give Professor Salah Daak. He can introduce this meeting and speak. I know he would be leaving very soon. So I will leave you to it, Professor.
Really, thank you very much for this opportunity, and also thank you for the arrangement for this really very important topic and give us the chance to share our experience. Definitely. Is it okay? The voice is okay? Hello?
Yes, we can hear you very well.
Thank you very much. Actually, thank you very much for giving us the chance to share our experience. Definitely everybody or every one of us has different experience according to the laws, according to the regulations in each country. Actually, the drug abuse in Sudan, recently there is a alarming increase in the drug abuse among young people in Sudan. The rise in drug abuse has been accompanied definitely by unprecedented rise in the crime. So there is the more there is abuse or drug abuse, the more crimes we are seeing in the community. And also we see the aggressive behavior. The people in Sudan really in the last few years are really shocked because of the new type of crime and of crimes, and also new type of behavior that the community is experiencing because of the drug abuse. Sometimes the crimes directed among the family of the victims or the drug users themselves. Like we found type of crimes within the family members, increasing, like person killing his brother, person killing another person, or hitting his parents. This kind of behavior in the past were not seen in Sudan commonly. But by recently or in the recent years, we used to see this kind of behavior among the family and toward their parents. I think it is high time that we combat, or at least we join our efforts together to combat drug abuse and raise awareness among the young people of the in Sudan and in Africa as a whole. There is one substance called ice. If you give it the same name in your country, have no. I think it has no stage of return. One dose of taking it or taking the ice, it is enough for you to get addicted from one dose, and not like heroin. I think it sometimes need to be to take more than one dose or maybe 3 doses till you get to the level of drug addiction. And I think ice is also very cheap substance, so the young people can really or can easily get it. The government of Sudan, in collaboration with all the military and the police and also police agencies and the UN agencies, now they are putting efforts together to combat the drug abuse. But I think that there are some problems in whether in the mechanism, whether in the commitment of these agencies towards drug combats. The UN, for example, declares that they can provide treatment to the victims, supplying the addiction treatment centers. But when I really look at it or look at the centers, sometimes I feel like there are nobody taking care of them. It is sometimes just a declaration. Sudan has been witnessing the growing drug abuse in the past decade with an explosive or under-reported increase in the numbers and also the cases. Like we can see there is an increase, but you don't see the data, you don't see the statistics. There is nobody actually, it is just like a hidden crime. So you don't see proper statistics that you can depend on. Though the reports on drugs being smuggled in Sudan already appeared in 1970. Okay. Since the 1970s, there was reports of drug smuggled in Sudan. But actually, it was only in 2003 that a specialized department was set up to combat drug trafficking. Yani, it is almost more than 40 years to manage to establish a department that can stand for this kind of drug or activities. In 2015, the country developed a national drug control strategy to enable the authority to work with non-governmental organizations in combating drug trafficking. And I think that was a good move. It is, yes, there, but definitely it is only on paper. But when you come and look at how they are doing their work, maybe because of funds, and as I said before, because of commitments, there is a problem in applying the laws. There is some people in Sudan consume the alcohol. It is common in Sudan, and mainly the traditional one, and also the cannabis. The cannabis, there is also increase. It is traditionally used and mainly grown in Darfur, in the valleys in Darfur, if you are familiar with the regions in Sudan. Roughly half of all youth arrested in Sudan because of theft, sometimes simple assaults, and because of drug abuse. But the unsuccessful, for me, I feel like the unsuccessful rehabilitation sometimes lead to relapse, and many people return to aggressive crimes to fulfill their needs. Sorry for the voice. Hello?
Yes, now we can hear you.
Okay, sorry. And I think one of the problems of the crimes is the unsuccessful rehabilitation sometimes lead to relapse. And many people, when they come back on the second or after relapse, they become more aggressive. And maybe to fulfill their needs, and because after relapse they come more experienced than before. Some people who are addicted often they have some difficulties, mainly academic difficulties, health-related problems, and poor relationship. And also sometimes it involves crime, but it goes into progressive from the academic difficulty till it comes to the full-blown picture of crimes. The root cause of crimes according to some studies in Sudan, the root cause of the crimes among the youth in Sudan, it is mainly poverty, unemployment, underemployment, sometimes racism and poor health, and definitely when it goes to when it comes drug abuse mixed with all this, then the picture is really very bad. The type of crimes among the youth here in Sudan, we have the violent crimes and also property crimes like looting and doing such kind of things, and also it goes up to the organized crimes. Sometimes it goes for major crimes like murder, rape, and also kidnapping, and all this. When they analyzed, they found that drug abuse and taking drugs behind committing such crimes. And I think I can stop here and give chance to my colleagues. Thank you very much.
Thank you very much, Professor Daak, for this very enlightening presentation about drug use and its link to crime in Sudan. It's interesting to know that the work against drug smuggling is ongoing right now. You said 40, it's been 40 years ago. So I think we're actually on the right path. The problem with drug in the African continent has been present for years now, but there wasn't efficient solutions. But the good news is that we're working on it right now. So I will give now the Professor Morgan Chetty, if you're available right now to intervene.
Thank you very much. Thanks for inviting me. I think Dr. Salah discussion and his issues he shared with us is very generic, and I think we have the same basic issues that he has, and what he said actually can be replicated. But I just want to look at it from a different perspective, in the sense that I just want to look at the challenges in Africa as a whole, and look at some of the issues in South Africa, and if time permits, or maybe during the session a little later, to talk about harm reduction principles, which I think are generic principles that will be adapted in each country based on the country's necessary challenges. But what the big problem in Africa is, and African Global Health will be addressing this, is that we don't have a central repository And unless we have meetings like we're having tonight, where individuals and experts from different countries share the information, we don't have a central repository of information in which we could target certain strategies in certain areas. I'll give you an example. In Africa, out of the 49 sub-Saharan countries, only 16 have data on injecting drug use. And these 16 are scattered around, and that information is not shared with everybody. So we are missing information, and the propensity of the situation is not being judged properly. So the most recent studies in Africa have shown there are over 52 million cannabis users. Certainly, cannabis is the number one drug of concern in South Africa, like it's in many parts of Africa. There are 6 million people, and these numbers can be larger than what I'm sharing with you, that use amphetamine type stimulants in Africa. Where they are is an important thing, because your strategy and the way you manage this patient will depend on the areas in which you will customize the management for. Then there are 3 million on cocaine, and that number is also, I think, underrated. 2 million in opioids. And this is a very big concern in South Africa, particularly. A lot of the drugs that are given over counter, a lot of the prescription drugs, which are legal drugs, become illegal because of abuse of the opioid content. And in our country, people can buy opioid containing analgesics, for example, over the counter. They can buy it from informal stores, and this is a rising issue in the country because we don't have a handle on this. There are about 2 million people on ecstasy just in South Africa alone. Right? Yet strict drug laws have escalated the public health crisis, and all these people that take these drugs seem to be also being afflicted and not being managed for HIV, hepatitis C, tuberculosis epidemics, while contributing to drug-related deaths. There are estimated that of the 2.3 million people who inject drugs identified in sub-Saharan Africa, 564,000 are living with HIV. So we also mustn't lose sight. There are issues of illicit drugs and licit drugs. And the important things like tobacco, which is legal to a point, but being controlled now, has its own potential to kill people, a potential of about 1 million people in the near future. And alcohol is predicted to kill 500 million people. So I just give you an overview of the drug use. So there is a study that's been done in South Africa in 2008 that found youth were almost twice as likely to have been victimized by violent crimes or some crimes or being involved in drugs. And that is a lot, twice as many as the adults. In South Africa, the National Youth Policy from 2009 till 2014 defines youth as persons from the age of 15 and 34 years of age. Why do I specify this? Because it's a very vulnerable age, and I think this is common throughout the other countries. So it's an important age because it's an age in which there's a transition from childhood into adolescence and into adulthood, a very vulnerable period in people's lives. There's no defined kind of objective to talk about. It's an important period for the development and change in the young person's life. And it's an important age where vulnerabilities in young people face. It's a time when there is a lack of independence, a lack of maturity to some extent, propensity to take risks, and a susceptibility to peer influences. In 2013, the non-natural deaths accounted for more than a third of all deaths of people between the ages of 15 and 29. A big factor we've seen during COVID in the rest of the world and also in South Africa is that one has to look at how the social determinants of health affect this particular population. And how does it affect them? The living conditions allow for this. They live in crowded communities. There's a lack of food security. People are forced to look at other ways of getting food. There's a huge amount of unemployment in this population. There's a lack of education to these people, the lack of opportunity for education, and also there's no impetus for these people to participate in an educational program. There's tremendous amount of crowding here, and we've seen this particularly in COVID, where we found that due to the crowding in these communities, we've actually promoted, or we allowed the virus to propagate, because people were living 5, 6, 7 in a room, and there was an issue here. So also there's a lot of violence in the home environment in this kind of communities. So what have they seen? They've seen a lot of intimate violence, and this is a bad example for the youth, between caregivers, violence between family members, abuse perpetrated against children. We see a lot of gender-based violence in these communities, and we see a lot of child abuse that goes unreported and unmanaged. So I'll quote again just to give you an idea in terms of the magnitude of it. The 2008 study, 53% of young people had often seen the families lose their tempers and end up in violent activities. 24% have been physically punished by their parents, and this doesn't augur well. 11% had some family members hurting one another. 11.1% have seen. Sorry, there's a lot of background noise there. Sorry, can I continue?
Yes, Professor, you can continue.
There's 11.1% I've seen family members intentionally attacking one another physically or with weapons. Also, there is a new thing that we're seeing in the country is violence in school amongst the youth and the use of drugs in youth in schools. And recently, there's a discussion that's going on in South Africa about school kids, minors, that are now vaping as an alternative to tobacco, and they seem to be doing it in the school premises. And then there is the new thing that's arising that's causing a lot of disturbance in the country, is bullying amongst the school children. So that's one. Then we have community violence, which I've discussed with you and told you about the overcrowding, etc. And then there's a peer environment in which we see peers tend to influence each other. And this seems to be quite a serious thing, because we don't think the schools and we don't think parents are having a hand in managing the peer pressures that their children face. So these are some of the issues that are amongst the crime, and as it says, the previous speaker has actually covered it well, so I won't waste time. What I'm going to do is do a little bit on the issue of harm reduction, and just do the principles of it only, not details, to look at some of the strategies that are in place, some of the approaches that are used, and the spin-off between duty of care and harm minimization, the impact of human rights on these people who are addicted or take drugs or involved in crime, and then the poor policies in place that result in us looking for zero tolerance rather than reducing the effect of it. We want to remove it completely, which doesn't happen. And then in some countries, deferring these people to criminalization, which is not a good thing, and some of the challenges in Africa. So if I look at it, it's what's important is that harm reduction is a potential set of strategies and its interventions and ideas aimed to reducing the negative consequences of certain healthcare behavior that afflict individuals. It is not intended to extinguish the problem. And if we go that route, we're not going to achieve much. There are two important strategies that we must emphasize. The strategies where some people are using zero tolerance strategy, which is not a good strategy for responding to harm. And it's problematic for the following reasons. It's inconsistent with the public health approach, which is very supportive approach. It's not paternalistic. It will not stop youth from the use of drugs, as I said, because it's got a paternalistic effect. People telling them what to do, and they're not informed of the potential hazards of the drug. And it fails to understand the underlying problems. And we need to understand each situation and each individual has its own set of problems that we need to look at. So harm reduction seeks to create an enabling environment following shared evidence-based information with the individuals. Now, criminalization, the use of drug, compromises the duty of care, which seeks to minimize harm for the drug abuse clients. So what are the current policies that we should be avoiding is criminalization, because it leads to a number of different things. It's a policy failure. We know that Kofi Annan said many years ago that government policies are a bigger driver of harm than the actual use of drugs. The criminalization leads to imprisonment in some countries. It leads to prohibition of medical care. It decreases the access of basic care, and it violates gross human rights. So I want to just touch on 2 or 3 things, and then we allow the others to talk here. I think the best approach is a combination of duty of care to reduce your harm and harm minimization. So what is duty of care? Duty of care is us taking reasonable care of a person. And under the laws of negligence, duty of care is breached when a person behaves unreasonably in action or inaction that results in harm to another person. What is reasonable will depend on the circumstances of a particular situation. Harm minimization, for the fact that we have very minimum time, I'm just going to give you the 3 big headings that we should work on. The first heading in harm minimization is how do we decrease the supply of these drugs? Secondly, how do we prevent the demand? And thirdly, how do we implement harm reduction strategies? And I want to conclude by saying harm reduction is grounded on justice and human rights. The right to healthcare, the Universal Declaration on Human Rights, confirms that everyone has a right to a standard of living adequate for health and the right to medical care and necessary social services. I think this is very important to understand. Anybody afflicted by the use of drugs does not give or does not forfeit their human rights, including the right to the highest attainable standards of health, to social services, to work, to benefit from scientific progress, freedom of arbitrary detention, and freedom from inhuman and degrading treatment. So in many countries, repressive drug laws have resulted in policies that have reinforced the status of people who use drugs as social outcasts, driving drugs into the underground. People do not come up for treatment because they've been ostracized in their communities. So I'm going to leave this at this stage and probably look at questions and answers later. But just to give you an overview that I think all of us, if we can follow a generic program and share our experiences in Africa, I think that is the intention of African Global Health, so that we will have a better lens into Africa by participation of individuals who are, some of them are on this program tonight. Thank you.
Well, thank you, Professor, for this very interesting intervention. It is true that we need to implement care regarding harm reduction strategies that we've been speaking about for a while now. We've been advocating for them, and I know how much you care about patient-centered care. So this is actually very it goes and it aligns with your research and with all your work. It is very important also. I think that research should be shared because, like you said, we don't have enough research in the continent, and unfortunately that is something that really sets us behind, and it doesn't help to move forward. R&D is definitely the way to go to start with, and of course harm reduction strategies are to be implemented according to that. Thank you very much, Professor. So now I will speak to Daniella Munene, who joined us earlier. Daniella is one of the organizers of this webinar. She agreed to speak about the subject of today, that is youth crime and addictions. Daniella.
Thank you, Sarah, and thank you to the previous speakers for setting the ground so well. I am going to give a perspective of Kenya, where I live. And in Kenya, we have an independent agency called the National Drug and Substance Abuse Agency, called NACADA, that exists for a nation free from alcohol and drug abuse. That's their motto. So I want to talk about the situation in Kenya and how it has improved or become worse over time with different drugs. As you know, a lot of sub-Saharan Africa has a very youthful population, and Kenya is no different. And a national survey on the status of drugs and substance abuse in 2022, it's quite recent, by NACADA, revealed that 1 in every 6 Kenyans aged 15 to 26 years were currently using at least one drug or substance of abuse, with males being 5 times more likely than females to be abusing drugs, and the capital city leading in prevalence. And it showed that in this age group, the most vulnerable were the young adults who've just finished college in their early to late 20s. And this was highly associated with unemployment. Now, the risk of depressive disorder was associated with drug use, with alcohol and cannabis demonstrating the highest association, where users of either of these 2 drugs were 2.3 times more likely than non-users to have a depressive disorder. And therefore, this reveals that addiction professionals, some of whom are on this call today, are having to deal with, and they have to think ahead on how to deal with the evolving challenge of this co-occurring scenario of substance abuse and mental health disorders. In Kenya, it's interesting to hear that South Africa, you know, the biggest drug of concern is cannabis. In Kenya, alcohol continues to be the most widely used substance of abuse. And this is similar to previous surveys in 2017 and 2012. However, the use of alcohol has declined somewhat. And this is because of very strict measures on illicit alcohol. So alcohol obviously is a licit drug in Kenya, but in previous years, there were a lot of illicit routes of accessing alcohol, people brewing in their houses in unhygienic, unsanitary, and unlicensed outlets, and the alcohol not being checked for alcohol content, many times being mixed with methanol and causing death, blindness, and other injury to the body. And because of very high alcohol content of the illegally brewed liquor, it caused addiction very quick. So because in the last 10 years, Kenya has really put measures to close down these alcohol brewing dens, and also where the legal alcohol is sold, it has been demarcated. It's not put on the shelf in the supermarket with other commodities. There has been a somewhat drop in alcohol use, but it is still the highest drug of abuse. Of concern, however, is that the prevalence of cannabis, which is the second most highly abused drug, has almost doubled over the last 5 years. And the growing demand for cannabis, especially among the youth, is attributed to the low perception of harm due to myths, misinformation, and misconceptions. Now, because Kenya has had an issue with alcohol, there's a lot of messaging, precautionary warning messaging around alcohol, but not so much around cannabis. And therefore, the cannabis abuse has almost doubled over the last 5 years. And the survey also showed that there was evidence of underage drug and substance use despite the well-documented negative implications and consequences of early initiation. Of very high concern was that some individuals were found to have initiated drug use as early as 6 years. Now, there was also evidence that the prevalence or the pervasiveness of mobile technology in Kenya and the culture of accessing things online has fueled the drug use epidemic in Kenya. And so, because Kenyans are very used to online channels for their other commodities, then the people who sell these drugs to youth, underage children, are using the online channel to access their market. And I'll just quickly summarize the recommendations that we've come up with as a country. The biggest recommendation is that more collaboration is needed. It's not the work of the drug abuse agency called NACADA alone, but there needs to be collaboration between the government agencies, schools, and NGOs, as well as private sector. For example, the brewers of licensed alcohol, in terms of messaging, in terms of compliance to regulations, there needs to be collaboration and constant dialogue, how to safeguard the youth of the country. And the second recommendation was that now that we've had some success with a very harsh messaging around alcohol abuse, and all the, we are very compliant with WHO guidelines on how to label alcohol and how to label even tobacco. It's time for positive messaging. And by positive messaging, I mean talking to the youth about, and schools about youth participation in sports, in the arts, activities that youth that are employed or youth that are unemployed can engage in, that will take their mind off being idle and accessing these drugs. We have focused on negative messaging, and it has had some effect on the dangers of drugs, but there's also space for positive messaging. And another recommendation was that more regulation is still needed to curb illicit alcohol because of the continued threat to health by taking unlicensed alcohol. So that's just a snapshot of the situation in Kenya. It will be interesting to watch the cannabis space because that is the fastest growing drug of abuse in the country. So Sarah, I'll stop there. I think I should also mention that, no surprise there was an association of drug use and crime, but that brings me to the end of my summary, and I'm keen to hear the experiences of other people on the call.
Thank you so much, Daniela. I am actually very surprised to hear that cannabis is becoming a popular drug in Kenya, because I always thought and read that this was a drug very common more in North Africa. But I think we discussed that during your symposium in Johannesburg, and the experts present were speaking about how cannabis was becoming popular. But the second drug after alcohol, it's gaining some land there. So I just have a question for you, Daniela. I know it's not the moment for it, but did you say that the youngest age that they start consumption is 6 years old?
Yes, they found that they surveyed 3,314 people between the age of 15 and 65 years. And they found the youngest to be 6 years old that had experimented with drugs. There was some 7-year-olds. There was a 10-year-old. So the age of first experiment was quite early.
Yeah. So, yeah, it's very disturbing, and I think that, well, when we see that there is an absolute need to establish, like you said, positive messages and harm reduction principles, which rely mostly on positive messages, and of course, all institutions should work together for the eradication of this problem. Thank you so much, Daniela. Thank you very much. Now I will ask Professor Terran to give us his opinion on the matter. Hola, Professor Enrique.
Thank you, Dr. Sarah, and thank you all you, the organizers, for inviting me to participate in this important and interesting meeting. I have been hearing very carefully the previous presentations, and I would start recognizing what important is the activity to try to collect data, because none of the potential interventions will be suitable without a baseline to be taken in consideration. So the most important thing is to create like a consortium to try to put all these data together to keep in mind what is the regional problem that we try to face and how to implement actions that are feasible to be widely implemented in the whole region. That is because, as we probably need to be aware, or we already are, these kind of problems, I mean addictions, need different and several point of interventions to be successful and to provide good results. The first one is to recognize that addictions are a health problem that need to be approached from the health point of view. So it's not a matter of decree, it's not a matter of taxes, it's not a matter of prohibition or a matter of law. People with addictions need definitely help to surpass addiction. And that means that our health system need to be prepared to support them. In most of the countries, unfortunately, and that is not happening only in Africa, it is also happening in Latin America and mainly worldwide, the health authorities are focused principally in prohibition. And that means that we forget that the conception of addiction is desensibilization. If we are not capable to give people with addiction any kind of support from the pharmacological point of view, from the psychological point of view, will be very difficult for them to live away addictions. If so, we need to create health systems that work in an integral way to provide those kind of support. The second problem is that, unfortunately, the more prohibition the government try to put, the more quick parallel markets, black market, counterfeit become more important. And this is quite more important in those areas like ours with borders that are not exactly strong to try to keep away counterfeit, to give away black market. So from my point of view and listening what was presented, we need to work together to get more data, to get more similar and comparable information, and we should start proposing integral actions to try to help people that is already affected with addiction, but even more important in the sense of harm reduction, to try to prevent newcomers into the addiction problem. Thank you, Dr. Sarah.
Thank you, Professor Terran. Thank you so much. I know it's 3 in the afternoon in Ecuador, so you must be really busy. It's not the end of the day where you are. So thank you very much for making the time to speak in this webinar. I think that what you brought in the subject is very important. The fact that we're speaking about the global South and Latin America is very important because we actually experiencing the same problems. Prohibition goes against the harm reduction principle, so that is absolutely very interesting. And the fact also that you spoke, like Daniela did, about the black market and the dark web to commercialize and to sell these drugs is it makes it difficult to contain. So maybe we should not go through prohibition, but work in different work with different solutions. Now I will ask Dr. Fares Mili from Tunisia to intervene. Dr. Fares, thank you very much.
Yes, hello, everybody. I want to thank Africa Harm Reduction staff for the invitation. Criminality is not my field of expertise, but I would like to shed light on 2 points which have closely relation with vulnerabilities to youth criminality. First of all, in most cases, juvenile delinquency as an expression of violent behavior involves impulsivity and aggressivity. The difficulty in controlling emotions, such as fear and anger, reflects a weakness in the brain structures dedicated to performing this task. The orbitofrontal cortex, the seat of executive functions, is hijacked. Brain chemistry plays a key role in this task. Some neuromediators such as dopamine, serotonin, noradrenaline, and GABA have been implicated in facilitating impulsive and aggressive behaviors. And allelic variations affecting dopamine and serotonin receptors in multiple publications are associated with a wide range of impulsive and even aggressive behaviors, especially when the possibility of using psychoactive substances becomes present and the environment in which these young people live accepts violence as an habitual mode of behavior. The second point I would like to emphasize is the importance of the environment in which these young people live. I would like to point out the family and the social environment where violence is accepted in all its forms. The act of violence thus becomes commonplace and therefore acceptable as a way of managing emotions and interpersonal relationships. This also applies to the school and out-of-school environment, which is beyond the control of adults and where violence can be tolerated and even sometimes seems necessary as a means of integrating into the peer group, just like the consumption of alcohol, psychoactive substances. This very special environment offers the first cigarette and allows experimentation with stimulating psychoactive substances that can lead to dependence and addiction. Preventing violence and crime among young people will be based on the two factors already discussed, and we need upstream actions. First is public information and education on domestic violence, as well as cultural and legislative work on domestic violence and violence against children, including sexual abuse. The second action is the primary prevention work, and it is to identify young people at risk of addiction and at risk of risky behaviors. The objectives of this work are to support these young people through targeted actions aimed at improving their self-esteem, personal assertiveness, and emotional management through physiological means such as adapted sports activities, cultural and artistic activities, associative and voluntary work, etc. And I don't like to end before saying this: before every youth crime, there is always a cry for help. If society is sufficiently attentive, many of these crimes can be avoided. That's what I would like to emphasize, and thank you for your attention.
Thank you very much, Dr. Fares, for your very interesting intervention. It's very interesting that you spoke about the neurobiological link between aggressive behavior and addiction. They are indeed very close and intricate. Since I think we finished with the main speakers, I have here Dr. Alexei Peter dos Santos from Brazil, who initially was not available but made himself available today. I would like to thank him very much. And if Dr. Alexei, you're here and you would like to intervene, we're listening to you.
Thank you, Sarah. Thank you for my participation. It's a pleasure to this first meeting, and I was impressed. I would like to thank Professor Morgan, Dr. Salah, Dr. Daniella, Dr. Enrique Terran from Ecuador, Dr. Fares. And I would like to say that I work as an oncologist in Brazil and as with education in Canada. And nowadays we are facing a huge discussion in Brazil about harm reduction. And I have a lot of issues that we discuss here about domestic violence, crimes, youth, and I really don't have the space to discuss about this. However, I think the connection between harm reduction and drug abuse is the start of harm reduction as a principle, as philosophy. And I think the data is important because here in Brazil, we're discussing a lot of data from England, from Canada, from US, and is not our population. And I think data is important in Africa and each country, and to get together data from many countries of Africa and even South America to have a similar population. And I think to face with drug abuse, it's really important to use harm reduction. And I was reading an article about harm reduction beyond drug abuse, and there are some principles. And I think these principles, like humanism, pragmatism, individualism, autonomy, incrementation, and accountability without termination is pretty important. And expanding the thoughts, I think it connects with domestic violence as well. And it's a way to face with this huge problem. But I agree, I totally agree with Dr. Enrique Terran that we need data, and we need specific data, because it's pretty difficult to import experience with different culture. For example, in Canada, people are not allowed to buy alcohol under 21 years old. In Brazil, it's easy to get alcohol for youth, and for example, and then it's difficult to compare. And we don't have in the system of education this kind of orientation, because we don't discuss drugs in the secondary school, for example, in Brazil, and we don't discuss so clearly as well in Canada. But I think the education is the final solution. But to get there, I would like to point out the pragmatism. We need some interventions that can change rapidly the situation and help people in need, because zero tolerance at the end of the day enlarge the distance of people getting help and enlarge the injustice scenario. That's my thoughts. Thank you.
Thank you very much, Dr. Dos Santos, for these enlightening thoughts. Thank you very much to everyone who intervened today. Daniella Munene actually had to drop off because it's, I think, 11 p.m. and it's time to sleep. Now, she actually shared with us in the discussion area the drug abuse situation in Kenya and the report she spoke about. Now I'd like to open the discussion if anyone would like to intervene or to ask a question to our experts. Professor Chetty, yes, please.
So I just want to clear up maybe I didn't make it clear, and Daniela is not here now. She's correct. Cannabis is not, when I said number one, I meant of the illicit drugs. And there's a lot of work being done in South Africa now to demarcate recreational use of cannabis versus medicinal use. And we're not promoting this for recreational use right now. So we're living in a gray area, but still in terms of the illicit drugs, alcohol and tobacco are the legal drugs, which if abused, cause the issues of harm in an individual. So I think she's been absolutely right, and maybe I didn't clear it up properly. Cannabis does not precede alcohol and tobacco as the big drugs of abuse. I just want to just clear that up. Thank you.
Yes, thank you, Professor. Thank you very much. Professor Rataiman.
Good evening. I just want to support what Professor Chetty said. When Daniela said she was surprised that alcohol is not at the top in South Africa as a substance of abuse, I was a little uneasy. I've been chair deputy chair and chair of the Central Drug Authority of South Africa for 10 years, from 1995 to 2005. And I visited all the sub-Saharan countries. We collected data there, which is collated by our Medical Research Council unit called SACENDU. And we found that in sub-Saharan Africa, alcohol really is still one of the worst substances for abuse. It's really at the top, followed by cannabis, and the other drugs follow. But the problem that occurs is that not only do young people and other elderly people use alcohol, but then they tend to mix it with other things. So cannabis comes to the fore because in different parts of the country, for instance, in the Western Cape, Prof. Chetty can confirm this, there's what they call white pipe, where cannabis is mixed with mandrax and other stimulants. And then also you find cannabis mixed with cheap, crack cocaine. And that leads to young people presenting in psychiatric wards in a psychotic-like state. And after a few days, they clear up. But when you test the blood or the urine, you find that they've been using these substances. So it's never just cannabis on its own. There's usually alcohol, there's usually some cheap cocaine and so on. But alcohol is still at the top. Now, on the 24th, 25th, and 26th of October in Cape Town, South Africa, we had a conference, an international conference called the Global Alcohol Policy Conference. Some of the things that came up, particularly with respect to young people, is that the policies from country to country in Africa, the whole continent, are different. Some countries appreciate the revenue from alcohol products, and they allow even cheap, untested alcohol to be sold. For instance, we heard about the alcohol sachets in Uganda and in Nigeria, and so on, and what the governments there are trying to do with that. But an important aspect that came up that leads to crime is poverty. They felt that the young people who were abusers, mainly of alcohol and also cannabis, were really from poor families, and they were jobless. And the idea was that in terms of recommendations to governments, we should encourage generation of jobs for young people. It doesn't have to be high-paying jobs or well-paying jobs, but we should actually be able to encourage young people to be very active in terms of getting some work that will make them more involved, more creative, so that they must be seen to belong to families. This sense of not belonging, of being useless and being ridiculed in society is a key problem. So in our interventions, I think we can look at the biochemistry, what alcohol and these drugs do in the brain, but the practical issues on the ground are these young people educated? Do they have jobs, or do they have things that keep them busy, so that going to get cheap alcohol or cheap drugs will be the way out? Once that report of the conference is consolidated, the Global Alcohol Policy Conference, I'll share it with African Global Health through Professor Chetty, and hopefully can add to this debate. But I'm sorry I connected late, but I am very happy and I was very thrilled with some of the contributions that were made. My friend Fares Mill and the other speakers, I think, captured the essence of what could cause violence in young people, particularly if they are subjected to, they're exposed to use of alcohol. The last thing I want to say is that a number of young people who appear to be violent do also have other underlying diseases, and they're never checked for that. So what is seen is just the use of alcohol or the use of cannabis and so on. There are a number of young people who have epilepsy that is not diagnosed or treated, subclinical epilepsy where you don't necessarily have fits and so on. Some may also be having subclinical HIV/AIDS, and then so and so on. So when we approach young people, we also have to examine them fully to make sure that they are not dealing with other comorbidities. Let me stop there and thank you very much for this webinar.
Thank you very much, Professor Solomon, for always having the very insightful remarks. It is absolutely true that we should need to look for other comorbidities or other conditions underlying the drug use, especially the alcohol use. Like as you are also a psychiatrist, you know that we can be also looking for psychiatric conditions that can be triggering this addiction. And once this condition is treated, the addiction can be tackled. So yeah, Dr. Terran has something to add.
Yes, thank you, Dr. Sarah. I think we have to stress that one important activity is to find the places to talk about these kind of issues. So this is one important compromise that came out from our last meeting and is part of the Marrakech Declaration, where we need to do these problems visible, because it is important, obviously, to talk about neglected diseases, about infectious diseases, but these kind of problems are somehow also in the shadow, and we need to speak up to put in the table the necessity of take actions to give advice to the authorities and plan together activities that will be really successful to make a change. So thank you for organizing this and for let people to discuss about this.
Thank you very much, Professor Terran. It is very important to discuss all subjects that were spoken about or that were dealt with in the last declaration and the previous declaration of Marrakech. The idea is to really elaborate and to have this final common charter that includes all these subjects that were discussed, and we're keeping the discussion to have a final charter that aligns with all experimented issues. Dr. Mili, you can go ahead.
Yes, just to emphasize that I fully agree with Dr. Solomon that alcohol is the main problem. Cannabis is recreational and relaxing the drug. Thus, it does not cause a huge problem, except if it is used and consumed with alcohol. And alcohol is the main problem, I think. And the way how we drink alcohol, I mean, binge drinking, for example, it's a main problem. And harm reduction could be a good issue, how to educate young people how to drink and not to drink with the binge drinking mode. Stimulant drugs are really very problematic, ecstasy, cocaine, especially, and crack maybe. But I will want to emphasize that cannabis is not really a big problem related to crime. And thank you.
Thank you, Dr. Fares, for your remarks. So if we don't have other remarks or questions for our experts, we will conclude this webinar. The webinar of December 7th, that is about youth crime and addiction, the harm reduction of
Hi, Sarah.
yes, Dr. Salah.
I think what has been discussed was really very useful. And I hope that if you, not only the conclusion to come into records, if they, you can come out with a summary to what has been discussed and the conclusion to be like documented in a paper or something. And that really will help in the future, even if you want to add it to any analysis in the future for one of the papers, that will help a lot.
Yes. Yes. So we can work on that. We can discuss that with the experts present in this webinar, and maybe we can write a joint paper about this matter. So once again, I would like to thank everyone for being and agreeing to intervene in this webinar by African Global Health in collaboration with Africa Health Business. Make sure you will tune in with our next webinars. We will send you the link. Next webinar will probably be next Wednesday. Thank you very much, and have a great evening and a great day for some.